Neurodegenerative and neurodevelopmental conditions, which perhaps look like it's two absolutely opposite conditions. The neurodevelopmental happens usually in kids and neurodegenerative in the senior adults. So seemingly it's two different topics, and somehow I managed to put it into one presentation. Let's figure out how that happened. Perhaps there are a lot of similarities in these conditions. We're going to find it out as the presentation goes. I have a disclaimer here. And before coming here, I've pulled up some statistics which is relevant to the United States of America. Some of it initially is global data. Like we have about, 9 billion people on this planet, but you know that we have around 40% of the global population who have, at least 40% who have some neurologic condition, some neurodegenerative condition. So we're talking about over 3 billion people affected. And there's been a tremendous rise in the past 30 years, like 71%. And in spite of all the headlines that this new drug has been discovered and that drug and all, it's all getting better. And we can see that global crisis in neurodegenerative conditions, it affects not only countries with a low income, but also countries with a high income as well. So it doesn't matter which part of the world you live, most likely you have very high chances to be affected by neurodegeneration. If we look at the data from World Health Organization, the money that has been spent on treatment of dementia is somewhere between the national budgets of such countries as Turkey and Indonesia. Indonesia is a very big country, by the way. It's, if I'm not mistaken, 4th largest in the world by population. And Turkey's economy is pretty strong, so it's a bit less than economy of Mexico. That's how much we are spending. That's the economy of dementia, unfortunately. And in the United States of America, well, I have to tell you, rather I'll be jumping forward, that the actual cost has not been established, okay? So all the calculations for the United States, it's perhaps it's a gross underestimate, but we're talking like hundreds of billions, okay? You can see all this data that was officially published for the United States of America. Hundreds of billions spent per year. If we're talking about Alzheimer's disease only, in this year, the expected expenses is like close to 400 billion. And there's a huge amount of money that, like almost 1/4 that is paid out of pocket. And there's a lot of cost which has not been included here as well. The neurodevelopmental conditions, not only autism and the autism spectrum disorders, but all neurodevelopmental conditions. It's about the same amount of money. Again, we're talking about hundreds of billions, close to 300 billion, 400 billion in 2025. 10 years ago, it was close to 300 billion. And the actual financial burden of neurodevelopmental conditions in USA per year also has not been completely established. But the number that really worries me is that personal or the individual cost, lifetime cost, it's over $1 million. It's starting from 1.5 million to 2.5 million, depending on the degree of the intellectual disability. It's a huge amount of money, and I'm not sure whether all families are capable of spending this money. So it means that if something can be done, to make any difference, any shift, in these numbers, definitely it will be of a great benefit for our community, for the human population on this planet, irrelevant of which country we're talking about. So the attempt to understand the mechanisms of neurodegenerative conditions and how to treat it. We have been writing a number of articles about it, and this year, 8 years ago, we have published a book which is called Stem Cells in Regenerative Medicine. In 8 years, the book became outdated and obsolete, so this year we are, this month, end of this month, it will be officially available and launched a new book which is called Stem Cells, The Untold. It has few chapters and much more data about treatment of neurodegenerative conditions than the previous book. It has separate chapters for the stroke, for the Alzheimer's disease, Parkinson, but also there is a special chapter, separate chapter that just discusses overall what are the pathways and the mechanisms and the etiology and pathogenesis of neurodevelopmental conditions. And just earlier this year, in April, in San Diego, there was a Autism Health Summit, and we have been presenting there as well. Our personal data, our clinics data on the treatment of neurodevelopmental conditions will be in the end of this lecture. But this is one of our specialties, if I dare say so. So the slide on the left, that video, I took it from some social media. It shows how two neurons in a petri dish are trying to reach out for each other and create a connection over here. And they actually do establish this connection eventually in this short video. And this, it's sort of in a micro, it's petabytes, some extremely high resolution. That's how the 1 millimeter of a human brain cortex looks like. And in that 1 millimeter, we have thousands and thousands of different neurons and different neuronal connections. So these two neurons create this, arguably perhaps the most complex structure in the entire universe. And it's a disruption in this architecture that cause all neurodegenerative conditions. But of course, this is not the complete list. And neurodevelopmental disorders as well. I call it as autism spectrum disorder plus. So what are the hallmarks of neurodegeneration? All neurodegenerative conditions, they have, in some way, they have all these hallmarks present. It's abnormal or aberrant proteostasis, loss of ability of the cells to clear up junk protein and pathological aggregation of the protein. It's a synaptic disruptions, neuronal disruptions, cytoskeletal abnormalities, so anatomical and functional abnormalities in the brain. And also, of course, there's some degree of the DNA and the RNA damage. And most importantly, altered energy homeostasis and chronic low-grade inflammation that ultimately cause neuronal death or abnormal neuron function. And if we compare this sort of like a good news, right? So those are the bad news. Now, what are the good news? The good news is that it's practically repeating all the hallmarks of aging. So any chronic disease of accumulation or any chronic degenerative condition has these 7 hallmarks present, and neurodegenerative conditions are not the exception. So we should treat neurodegenerative condition with the same approach generally, like in which direction should we run to, where to run, for us to successfully reach the point. Treat it as the chronic degenerative condition. If we look at the neurodevelopmental conditions, we're talking about again, there's a split between the high-income and the low-income countries. If we look at the hearing loss, for instance, or the developmental intellectual disability, it seems like it more happens in the lower-income countries. Well, because the high-income countries have the better tools to diagnose it earlier and treat it earlier. But autism spectrum disorder, and especially the ADHD, it's definitely more prevalent in high-income countries. And you can see the percentage. We talk about 1 in 100 to 1 in 60 kids. Well, it's difficult to put a number, but the ASD itself is definitely 3% and above of all the kids. So it's really a huge number. of patients that are involved. And the number is getting worse and worse. It's progressively is growing. It's not just because the population is growing, but the occurrence, the prevalence of this pathology is also, unfortunately, is increasing. If we look at the symptomatology, so the presentation is going to be that it's going to be the alternation sort of in the beginning of neurodegeneration and the neurodevelopmental conditions, but it all will come to the same conclusion. So if you look at the symptomatology of the autism spectrum disorders, we have sort of like three groups, you know. It's mostly social communication, it's a speech disorders and restrictive repetitive patterns of behavior. But as everything in neurology, these conditions also have their topical diagnosis. So for every clinical presentation or every group of symptoms, there is an anatomical background for that. Specific areas in the brain, specific cells in the brain, the dysfunction of those areas responsible for specific symptoms. It's very, very important to understand that. And the same pattern is present in all neurodegenerative conditions as well. Whether we're talking on the organ level, yes, it's the brain affected, but various neurodegenerative conditions have various parts of the brain affected, different cells as well. It's all neurons, but they're different neurons, structurally and functionally as well. And there are, as we go deeper on the molecular level, the specificity is becoming more and more pronounced. But again, in the same time, the mechanism, the drivers or the hallmarks stay and remain the same. And it turns out that there's a lot of parallels, there's a lot of similarities between neurodegenerative and neurodevelopmental conditions. For instance, if we look at the beta amyloid plaques, we know that it's one of the hallmarks of Alzheimer's disease, but it's present in practically all kids with autism. And the severity of the accumulation of the beta amyloid is about the same. If we compare autism spectrum disorders, or ASD, with the Parkinson, we find that the abnormal functioning of the alpha-synuclein gene is present in these both conditions. And the Lewy bodies accumulation is also present in both conditions. And statistically speaking, by the age of 28, 30, and early 30s, a lot of the untreated, especially the untreated ASD individuals, they begin to acquire clinical manifestations of Alzheimer's disease. And the occurrence of Parkinson in those who have been diagnosed with ASD is tens of folds. It's like close to 30 times higher than in otherwise in a non-ASD brain. ASD has specific patterns of growth of development, especially of the brain cortex. And that depends on the years. So in early years of life, between 2 to 4 years, there's usually a very rapid, accelerated growth of total brain volume that happens in the first from 2 to 4 years old. And mostly it involves the frontal and the temporal lobes. And we observe something like the accelerated expansion of the cortical surface area, gray matter, but not the cortical thickness. The cortical thickness actually is reducing. That's why if you do the scan with the densitometry, there's clearly specific areas, especially like corpus callosum, have a much lesser tissue density compared to the non-ASD brain. And also there's an impaired maturation of the cortical white matter. And interestingly, that this arrest of this growth happens between 10 to 15 years old, and then in the late 20s, the changes in the autistic brain begin to develop the changes in the same progressive cerebral atrophy as happens in Alzheimer's patients. And as they go further in life, it's more and more and more resembling Alzheimer's disease when it's not treated. Amygdala is also affected grossly in ASD brain. There's also increased volume, increased amount of the neurons and synaptic density, which happens between 4, 5, 6 years old. Then after that, after teenagehood and all, absolutely opposite happens. And if we look at the PTSD patients, the involvement of the hippocampus and amygdala and the prefrontal cortex in PTSD has absolutely the same pattern as autism as well. So there's a lot of similarities morphologically. And there's a lot of similarities in terms of the neuroinflammation. The microglial and the astrocytic activation are present both in ASD and neurodegenerative conditions. The hyperactivation of the M1 microglia and the macrophages, abnormal activation, and the abnormal activation of the B cells with the expression of the pro-inflammatory cytokines. It's an absolutely universal mechanism for all neurodegenerative and neurodevelopmental conditions. Excitotoxicity. What it means, it's the overactivation of the glutamate receptors. But it happens due to the calcium increased calcium influx, and it keeps on circulating, being reused together with because of the glutamate receptor and the transporter in the synapse. It causes neuronal swelling, and it causes seizures. About 30% of the ASD kids are prone to seizures. And the worst, neuronal death, again, if it's not treated. We talk a lot about the neurotoxicity present both in ASD and neurodegenerative conditions as well. Now, I do understand that there's been some talks about the vaccines and all, but if we look at the actual studies, when I mentioned about it in San Diego and the autism, there was like a wave, like in the audience, because a lot of people disagreed with that. And then they did ask the question regarding the vaccines, and also my answer was very simple. Did you read the paper? Did you read the actual papers? Because it's all in a paper. In the papers, the actual studies, they clearly show that there is no connection between the thimerosal and the vaccines and the ASD. Absolutely, there is no connections. Please read the paper. Yeah, let's not talk about it today. But what actually matters is the aluminum or aluminum, I don't know, it depends whether you're American English or English, right? And the mercury less, but the aluminum toxicity and the lead toxicity is very important. And where it's coming from, it's usually is endemic. So certain areas, like if we look at the studies where actually it was detected, it's mostly in the Middle East, Dubai or the Egypt and all, and how it gets there, how we get this toxicity, difficult to say. Perhaps from the water, the food, I don't know, it's difficult to say, but unlikely it's from the vaccines or something like that. However, there is an opinion that as the kids may have a certain gene present that will reduce the capacity of the brain tissue to remove certain heavy metals and even not the heavy metals, just the aluminum removed from its tissue. Well, that's a possibility, but we don't know the mechanism. What we know is that, yes, in certain patients, in a high percentage, if you test the patient and the abnormal presence of, say, aluminum in the patient is associated with poor cognitive function. Metabolic dysfunctions. In autistic brain, we're talking about 500 times higher prevalence of the mitochondrial dysfunction than a general population. At least 30% of the patients, they have ASD patients, they have clear-cut metabolic abnormalities that are very easy to detect with tests. And 60% of ASD patients with seizures have underlying mitochondrial disease. What about the neurodegeneration? Full on, practically the same what we see in the metabolic syndrome, the diabetes type 2. It's the insulin resistance, IGF-1 and leptin resistance, hyperactivation of the mTOR, reduced autophagy, same as we observe in patients with a metabolic syndrome. We see it in all neurodegenerative conditions. So what to do? What to do, we have discussed in the books and the articles that we have published, and it zooms down to two things: promote structural and functional neuroplasticity. Create new neurons, harness the neurons that are present, stimulate adult neurogenesis, and stimulate creation of more neuronal connections between neurons. In our setting, in our center, we're here. We're in the very, very last. We never take the patient from the very beginning. We take the referrals from other practitioners. And this algorithm, mostly initially it was created for the ASD, and then we have adapted it for neurodevelopmental and neurodegenerative disorders as well. So it all starts with the primary diagnosis, with a neurologist or with a pediatrician, then diagnostic stage, then total lifetime adjustments, removal of toxins, look for the cause. If there is some, if there are some tests that show high metal, heavy metals and aluminum and other toxicity, we'll try to remove that. Nutritional changes and all, and then behavioral, speech, occupational therapy, all medical therapy, and in the end they come to us for biologicals and regenerative medicine. So the cornerstone of regen medicine are the stem cells, and it's a specific neural progenitor stem cells, which even further on for different neurodevelopmental and neurodegenerative conditions can be even more specified. For instance, patients with Parkinson, mostly it would be the dopaminergic cells. For patients with Alzheimer's, just the general neural progenitors. For kids with the ASD, we're trying to go as much topical as possible, you know, when we prepare our xenografts. Second would be the neuropeptides, whether we use two types of the neuropeptides. They're procured from the cultured neural progenitor stem cells. The nanomized nanopeptides, very high bioavailability, they easy penetrate blood-brain barrier. It's completely not a problem. The size, molecular weight is very low, and the mitochondrial fraction, it's basically the nanopeptides with enriched mitochondrial peptides that we created our own formulation, which is called mitoorganelles. Phospholipids, choline donors, and phosphate donors. Plaques, it's the acetylcholine, it's a choline donor. It's very important for, it's a precursor of the neuromediator. And creatine, we're talking about not the 5-7 gram that everyone heard of, a high dose of creatine monohydrate, 20 gram and above. What is missing here for both, and especially, of course, for neurodegenerative conditions, is the MCTs. I haven't included MCTs, so usually we give on a fasted state early in the morning about 5 to 7 gram mid-chain triglycerides. I personally prefer it's an oil from Sri Lanka. This is a specific brand, you know, which really high quality of the mid-chain triglycerides, the coconut oil. In the part of the world where I live and work in Southeast Asia, it's not a problem, okay? So I order always for my patients the Sri Lankan coconut oil 5 to 7 gram first thing in the morning. They have to be in a fasted state, and then you're not supposed to feed patient for another couple of hours, because the switches of nutrition in the brain, it works. It's either carbohydrates or the MCTs, right? And the moment you introduce an alternative or the main nutrient to the brain will uptake. Even if you give just 1 millimole of glucose, the uptake will switch to the carbohydrate pathway. And all the MCTs that you give to the patient will go straight to the liver, will be deposited there 3 to 4 months. Non-fatty liver, fatty liver disease, non-alcoholic fatty liver disease is guaranteed. So the timing is very, very important here. Pediatric practice, we use macrophage activator. It's the activator of phagocytosis. Because of that abnormal M1 macrophages, we do not use that in neurodevelopmental conditions. In neurodegenerative conditions, we use that in neurodevelopmental only. We pay a lot of attention to the micronutrients, especially the vitamin B complex, magnesium, folic acid, and GABA in therapeutic doses. Probiotics and heavy metal detox, gut detox, and different devices which we use around stem cells, including even the mannitol plus the theta chamber transcranial stimulation that helps to open up the blood-brain barrier as much as possible and helps with the uptake of the biologicals that we give to the patient. But even after that, because stem cells create that wonderful window of opportunity, which will last for a few months. And that window of opportunity, it's sort of a unique time when brain can really develop rapidly. So all these devices, including the hyperbaric oxygenation, transcranial electromagnetic, we use extensively within the first at least 3 to 4 months after the stem cell implantation. And we are talking about at least 40 sessions of each of it that ultimately will give clinical, has any clinical significance. So 1, 2, 5, 10, 15, 20 sessions now. It has to be way more than that, minimum 40 sessions and above. So what is the evidence? Are we the only one who've been using specific progenitor cells, neurogenic cells, or neuronal stem cells for patients with ASD? Nope. It has been done before us, including in the United States, and the Bread State was doing that together with some East European help. If we look at the data from Italy and France, there's a very interesting article. It's a meta-analysis of neuronal cell xenotransplantation patients with neurodegenerative disorders. They predominantly focused on Parkinson and post-stroke patients, and they have been able to demonstrate in this paper that the fetal cells, they have ability to migrate, survive in the brain up to 7 months, then further differentiate and support dopaminergic neurons and hence reduce the symptoms. If we look back at almost a quarter of a century, there was a very interesting clinical trial, involved 12 patients, the clinical trial on Parkinson's disease. They transplanted porcine neurogenic progenitor stem cells. 9 months after transplantation, one of the patients died because of the pulmonary embolism that was not related to the procedure, but because he was a part of the clinical trial, went for post-mortem. And 9 months after the implantation of a xenogenic progenitors in a 69-year-old patient with a 15 years history of Parkinson, who demonstrated quite a good recovery from Parkinsonian symptoms after the transplantation. So 9 months after that, he was positive for the CD44 antigen staining. That shows that it's a presence of the xenogenic, it's a foreign cells, foreign tissue there. It was positive for the tyrosine hydroxylase, which is a marker for dopamine. And it was positive for the neurofilament 70 marker, which shows that the transplanted foreign cells created actual connection, cell-to-cell connection with the patient's resident cells. If we look at the outcomes, the score in the data, the efficacy of neuronal fetal stem cells, progenitor cells in treatment of ASD, and this is not our data. This data actually is from the United States, so it's a third-party data, and they show that there's a reduction of the scoring and improvement of speech, sociability, cognitive, and behavioral patterns within the first 1 year after the transplantation. Our own data. Now, this data also is a little bit outdated because I have calculated it during the pandemic. So the data of the past 4 years has not been included here. So what we had in the beginning of 2020s, we had our own clinics treated 590 patients, predominantly boys, of course, from 16 countries, if I'm not mistaken. It's not mentioned here, but I'm from 16 countries. And if we look at the amount of patients, 590, but we had 910 stem cell implantations. Why? Because only 41% had one implantation, and the rest, 59, had multiple implantation. Up to 7 times, 15% of the patients had 7 implantations. They were coming back and keep on coming back, even after, some of them after decade. Some of the patients, my patients, I know them since the age of 8, 9 years old, and they're teenagers now. Predominantly boys, 70%, less girls, and in total, we treated from 16 countries. It's more than that now. If we look at the age, yes, it's usually the primary school, and then the transition from the primary to secondary school would be the second peak when parents and families would be bringing their kids, because they just, they always compare to cousin's kid, to a brother's kid, you know, and so on and so forth. And because of that comparison, you know, they come every time with new demands, you know, because we want more, we want more. And absolutely fine. I keep on telling them all that you need to do is just have patience, because this can go on at least till the age of 25 years old, you know, when the brain is developing, and perhaps even beyond that. So what are the outcomes? Improved social relationship, it's improved cognition, improved speech and language patterns. I had a patient that earlier last year, father asked for he asked for an appointment 4 months after transplantation. So he came without his wife, without the kid, and all just to see me. And he's a pilot. He's a pilot for Qatar Airways, and he is at home quite rarely. So we treated an 11-year-old child who was absolute. He couldn't speak a sentence. On January was the implantation, and in May, father comes and says he cannot be happier because he said, first time in my life, my son speaks full sentences to me. That's just in 3 to 4 months. This is our own data, improvement in an ATEC score and the total score throughout the year. And recently, there's been a very interesting paper published titled Clinical Case of Successful Therapy for the Patient with Autism by Use of Fetal Stem Cells, where they, of course, discuss the mechanisms. You can see them. Please take the photo of this. These are the mechanisms through which the effect is produced. And this is the functional MRI, because initially, the patient had damage on the left in the cingulate, arcuate, and upper longitudinal pathways on the left. 6 months after transplantation, had a restoration of the cingulate pathway and partial restoration of the temporal part of the arcuate pathway. And the article, the paper, has all the necessary images, and they've concluded that progenitor cells, they contribute to neurogenesis, regeneration of the CNS, they decrease inflammation, they also work as the MSCs in the same way, they improve microcirculation, promote neuroprotection because they express they promote neuroangiogenesis, they reduce microglial overexcitation and neuroinflammation, and they promote remyelinization of the tissue, hence improve the functional recovery of the affected brain. Please visit our website. You can see a lot of clinical testimonials and clinical cases there, where patients and their relatives and the caretakers from all parts of the world, they give testimony of the treatment. Thank you very much.